Today I will be talking about techniques of labor analgesia, its advantages and disadvantages. I am Dr. Mahima Lakhanpal from Department of Anaesthesia, Santosh Medical College. So what are the goals of labor analgesia? They are to dramatically reduce the pain of labor. They should allow participants to participate in birth-giving experience, minimal motor block to allow ambulation, minimal effect on fetus and minimal effect on the progress of labor. There are techniques, non-regional techniques and regional techniques. In non-regional techniques, we have non-pharmacological techniques and pharmacological techniques. So non-pharmacological techniques have hypnosis, massage, acupuncture, TENS, acupuncture, aeropathy and water immersion. Whereas pharmacological techniques, we have inhalational agents and systemic analgesics. In regional techniques, we have spinal, epidural, combined spinal epidural and paracervical block. So coming to the non-regional techniques, first we have the non-pharmacological techniques. The advantages are these are easy to administer and they have many minimal side effects. But the disadvantages, we have very little evidence to support the efficacy and some are costly and they are time consuming also. In non-pharmacological techniques, the most commonly used they are the transcutaneous electrical nerve stimulation, that is TENS, water immersion or acupuncture. In the pharmacological techniques, we have inhalational agents in which we can use Antinox and sevoflurane. Now using Antinox, that is 50% oxygen and 50% nitrous oxide, the advantages are they are easy to use, there is no requirement of physician supervision and they have minimal accumulation. Whereas the disadvantages are they are not potent analgesics and they are environmental pollutants also. In sevoflurane, the advantage is it is short acting and the short onset and offset is there. It can be administered as patient controlled inhalational agent also, but the disadvantage is it causes maternal amnesia, loss of protective airway reflex and again it is an environmental pollutant. In pharmacological techniques, then we have systemic opioids in which we can use pethidine, tramadol, butorphanol, fentanyl or remifentanil. Most commonly used are fentanyl and remifentanil. Fentanyl, it has a rapid onset, that is 2 to 3 minutes. It has a short duration of action. It has no active metabolite. So it can be given in a bolus of 25 to 50 microgram per hour or an infusion of 0.25 microgram per hour per kg per hour. And it is suitable for patient controlled analgesia also. In remifentanil, it is an ultra short acting drug with a T-half of 6 minutes. It is metabolite to inactive metabolites and used for patient controlled analgesia. But it requires extensive monitoring because it may cause maternal hypoventilation. Patient controlled analgesia, we can use 20 microgram with 3-minute lockdown period and the infusion of initially we can start with 0.025 microgram per kg per minute and maximum of 0.15 microgram per kg per minute. In regional anesthesia, we have spinal technique, epidural analgesia, combined spinal epidural analgesia, paracervical and pudendal block. So, spinal analgesia mainly given in sitting or lying down position at the level of L4, L5 or L3, L4. And the advantages of neuraxial labor analgesia are they give complete analgesia, there is no sedation, mother actively participates in the birth, mitigates the delirious reflex pain, response to pain, minimal or no neonatal sedation is there, conversion into surgical anesthesia if urgent LSCS is required is possible, and it also improves the uteroplacental flow. Whereas the disadvantages is it requires a skilled anesthetist, it can occasionally result in failed block also, it causes maternal hypertension sometimes and more chances of dural puncture are there in pregnant patients. And it is contraindicated where the patient refuses to take the block, coagulopathies, hypovolemia, untreated systemic infection, local infection at the site and lumbar spine pathology. Now for local anesthetics that are used in neuraxial block, they are bupivacaine, ropivacaine or levobupivacaine. All are equipotent, but bupivacaine has more motor block whereas ropiva and levobupivacaine has less motor block, that is therefore they are preferred. And also bupivacaine is more cardiotoxic as compared to ropivacaine and levobupivacaine. Then we can use adjuvants along with the local anesthetic in neuroaxial blocks like fentanyl, sufentanil, remifentanil. They have a synergistic effect by acting directly on the spinal receptors, the opioid receptors in the spinal cord. And they also help reduce the local anesthetic requirement. So most commonly used are fentanyl and sufentanil. Then we can also use clonidine, which is an alpha-2 agonist, but it might cause sedation or hypotension and is not FDA approved also. Neostigmine is another drug which can be used as an adjuvant. Now coming to spinal anesthesia, we can either use a single shot or continuous spinal anesthesia. So in single shot subarachnoid block or spinal anesthesia, the local anesthetic or opioid can provide effective and rapid onset of labor analgesia. It is effective in late, rapidly progressing labor, and in distress participants it helps us to enable to put an epidural also. So we can put a low dose of spinal and then try to put an epidural catheter. Instrumental deliveries in women who do not have an indwelling epidural catheter can also be done by spinal anesthesia. So the drug use can be bupivacaine in the dose of 1 to 2.5 milligram, and along with the opioids like fentanyl 20 to 25 microgram or sufentanil 3 to 5 microgram. Then we have continuous spinal analgesia. In this CSE with microcatheters can be used with the size of 28 gauge. Intermittent boluses or continuous infusion techniques can be used. The advantage of this is a better pain relief and higher maternal satisfaction. Whereas the disadvantages, they can cause cauda equina syndrome, catheter failure can be there, technical difficulties, and they can be expensive also. Now coming to epidural analgesia, they are safe and effective method of pain relief. The ability to extend the duration of block to match the duration of labor is possible by this. It may be extended to provide anesthesia for instrumental or operative delivery. It blunts the hemodynamic effects of uterine contractions, that it is very beneficial for patients with preeclampsia, and it decreases the maternal hyperventilation. Now with the painful uterine contractions, it causes maternal hyperventilation, which causes hypocapnia, and it shifts the maternal oxyhemoglobin dissociation curve to the left, which increases the oxygen affinity, and thus it reduces the fetal oxygen delivery also. In turn, the hyperventilation, which causes hypocapnia, can also result in hypoventilation between the contractions that can again lead to fetal oxygen delivery, reduced fetal oxygen delivery. So all these effects, they are blunted by giving epidural analgesia. So epidural analgesia can be traditional epidural, it can be a low dose epidural, walking epidural, patient controlled epidural analgesia, or continuous epidural infusion. So in traditional epidural analgesia, we are using 0.25% of bupivacaine, but it has a high incidence of motor block. Therefore, it is not used. Low dose epidural is using minimal local anesthetic dose and volume, around 0.0625% or 0.125% of local anesthetic, along with the opioids like fentanyl or sufentanil. It increases the rate of normal vaginal delivery, decreases the rate of instrumental vaginal delivery, and also decreases the rate of complications of local anesthetic toxicity. So it is very dilute local anesthetic mixtures like 0.0625%. They do not produce any motor blockage, so the patient can ambulate, and that is why it is also known as the walking or mobile epidural. So what is the advantage of walking epidural? First, the upright position will help to shorten the duration of labor by walking, and the weight of the fetus will dilate the cervix. That is why we prefer low dose epidural. Patient controlled epidural analgesia, it is safe and effective technique. Excellent patient satisfaction is there. It reduces the total amount of local anesthetic that is used, and also reduces the demand on staff on the labor floor. It gives many patrons a feeling of empowerment, and the catheter is connected to the PCA device, and the patient can then self-administer further boluses as and when required. So we can use bupivacaine along with the opioids in this also. We set the amount of bolus that can be given, the infusion rate, and the lockout time can be set on the PCA machine. So the disadvantage of demand only method over the continuous infusion plus demand is that there is increased incidence of breakthrough pain when we are given analgesic only on demand. There is shorter duration of effective analgesia and a low maternal satisfaction. Therefore, a continuous infusion with demand plus demand dose is preferred over just demand dose. Computer integrated PCA pumps, they control the background infusion rate depending on previous hour's demand bolus. It is useful in patients with prolonged labor and hourly consumption is not less than the PCA group. Now, continuous epidural, the advantages are safe for both mother and neonate. They have better pain relief, and the disadvantage is they cause more numbness and motor block, more breakthrough top-ups, and total dosage of the local anesthetic is higher. So again, we can use bupivacaine, ropivacaine along with adjuvants like fentanyl and sufentanil for continuous epidural infusions. Now, after spinal and epidural, we can also use combined spinal and epidural. That is, we can give a very low dose of spinal and then put an epidural catheter and continue an epidural infusion through that catheter. So what is the advantage of combined spinal epidural? That is, it is rapid, reliable onset resulting from spinal injection, flexibility and longer duration of epidural techniques. Use of spinal opioids provide immediate analgesia without any motor block, thus providing an ambulatory block, which is walking epidural, and epidural catheters activated with low dose mixture of opioid and local anesthetic, hence the ability to walk is not impaired. The complications of combined spinal epidural can be uterine hypertonicity or fetal bradycardia. The Obstetric Anaesthetists Association UK guidelines in 2005, they restricted the use of CSE as a routine because of the fetal bradycardia and the hypertonicity of uterine. Indications were only for specific situations like very early stage of labor where local anesthetic was avoided, advanced stage of labor where rapid analgesia was required, and difficult epidurals. Now we can also use ultrasonography for patients where epidural space is not identified or is difficult to identify, like in obese patients or patients have scoliosis. So it minimizes the epidural failure rates. Now what are the new insights into the myths and the controversies of epidural analgesia? First is, there is a myth that increased rate of operative and instrumental delivery is there. So is epidural the cause? So the trials show that there is no direct relationship of epidural and decreased cesarean sections. It is known to prolong duration of labor on an average of just 1 hour, and instrumental delivery is relatively higher. So the use of low dose mixtures reduce the overall incidence of these undesirable adverse effects. So low dose epidural infusion was associated with 25% decrease in the instrumental vaginal delivery. Then the timing of epidural during labor, whether it should be put in early labor versus late labor. So the study showed that there was no difference in the operative delivery of cesarean rates when Neuraxil analgesia was administered early in labor, whether the cervical dilatation was 2 centimeters versus in a group where the epidural analgesia was administered late in labor, that is 4 to 5 centimeters. So the American Society of Anaesthesia have emphasized there is no need to put cervical dilatation has reached 4 to 5 centimeters and endorsed a statement that maternal risk is the only sufficient indication for pain relief. Early versus delayed pushing, there were delayed pushing in parturients under neuraxial block. So the pushing early or pushing late with the epidural study also supported delayed pushing for a better outcome. Withholding the epidural top-ups in the second stage, significant increase in the inadequate pain relief was seen when there was epidural was stopped in the second stage of labor. Therefore, it is recommended that it should be continued. Vaginal birth after cesarean and epidural. The Task Force Guidelines 2007, they jointly issued by the ASA and the Society of Obstetric Anesthesia recommended that neuraxial technique for patients attempt vaginal birth after previous cesarean delivery. Epidural and breastfeeding, though it has been seen that it does not have much effect, but further studies are still needed. Maternal pyrexia and newborn, so there has been an increase of around 1 degree centigrade of the temperature, which can be treated by hydration, antipyretics and appropriate measures. Postdural puncture headaches, very small bone needles and atraumatic needles, they have already reduced the incidence by 1% or less. Then we can also put beside the spinal, epidural and combined spinal, we have the paracervical blocks and the pudendal blocks that can be used for labor analgesia. So the key points are: main pain of labor is severe and many women seek ways to reduce it. Non-regional techniques include supportive measures, inhalational agents and parenteral opioid administration, and neuraxial analgesia provide a good quality of pain relief in labor. Thank you.